So back to lectures, right? Okay.
Yeah, thank you very much. Thank you, everyone. So we will go ahead with the cartilage talk. I will be talking about the graft-based cartilage solutions with specific mention of oats, mosaicplasty, and minced articular cartilage. I'm not able to move. Yep, I'm Dr. Saseendar, Professor of Orthopedics from Pondicherry, India. I'm not going into the details of what and which method of cartilage reconstruction or repair we have to do. I will go on directly to OATS, that is osteochondral autograft transfer. This is basically a trademark. The better way to say it should be osteochondral cylinder transfer. It basically consists of a cylinder of the cartilage and the subchondral bone that is harvested from a relatively non-weight bearing area and placed to the painful weight bearing region in order to reduce the pain and also to encourage healing and reduce the progress of osteoarthritis. So it involves a system that is the OATS transfer system. Previously we used to have the mosaicplasty system. This is a slight modification of that. You have the, as I said, you have the cartilage from donor area that can be from the edge of the condyles or from the trochlea, and also from the sulcus terminalis region, that is the edge of the femoral notch, where it is not weight bearing but still you could have a good size of cartilage that can be harvested. Case example, 15-year female, pain in the knee for more than 6 months, no specific history of trauma, possibly it was missed. The MRI images, medial femoral condyle, classical location. Sometimes it can be even closer to the notch. So that's type 3 osteochondral lesion in the medial femoral condyle. This is quite a large lesion anteroposteriorly, though it is not so large mediolaterally. We proceeded with diagnostic arthroscopy. That's a type 4 chondral lesion. Then after identifying the exact location of the femoral condyle lesion, we went in with a small incision, like 3 centimeter incision over the exact location of the chondral lesion. The osteochondral flap was removed, that was not salvageable. The edges are freshened after the removal of the flap. Use a curette to freshen the edges. If there are calcified edges, those have to be removed also. And if the floor is calcified, that has to be curated well until a little bit of bleeding bone is there. Take into consideration the patient may be under tourniquet, so bleeding may be less. Then you go on to identify an appropriate location of the donor site. If the affected area is in the edge of the femoral condyle, you have to choose a correspondingly shaped surface of the donor site in order to match the surface of the recipient area. And then finally make sure the depth of the osteochondral cylinder that you have harvested is appropriate. If it is too long, you have to nibble off a little bit of the bone underneath. Then you have to prepare the receptor area, match the depth of the size accordingly based on the donor depth and the recipient area depth, and then push in the donor cylinder into the recipient area in order to create a well matched surface over there. It should not be too proud, and there is no point in having a sunk cylinder over there. So this is the patient postoperatively at 3 weeks. The benefit with OATS procedure is the rehabilitation can be very quick and the rate of union is very high, whereas the disadvantages can include donor site complications, pain, anterior knee pain. So what is the current evidence? It is the best treatment option that is available for small and mid-sized lesions, especially from 2 to 4 centimeters square. and best suited for young patients. The results are best for the femoral condyle lesions more than tibial lesions, more than trochlear or patellar lesions. The return to sports can be as high as 91% at 7 months. In comparison to MASI, that is matrix associated autologous chondrocyte implantation and microfracture, OATS appears to be the best treatment option. Advantages include low cost, return to sports is very quick, and also the rate of return to sports is very high. This is an example of OATS procedure for the talus. This is an arthroscopy of the ankle showing the osteochondral lesion over there. Went in with medial malleolar osteotomy, appropriate surface of donor side from the knee, transferred over there, medial malleolar screw. Postoperatively, the patient is able to get back to regular physical activity. However, you have to make sure that you are matching the donor site and the recipient surfaces appropriately. If they are not matching appropriately, then you have a mismatched surface in the recipient area. This is not so well done transfer. This is not good for the patient. Okay, for the patella, again you can you have other options, cell-based reconstruction procedures, but if you want to go ahead with an OATS, it is best to do. It is only possible to do with a mini open incision. Okay, going on to mosaicplasty. Mosaicplasty is an age-old treatment procedure wherein you use multiple cylinders in order to fill in a large area of osteochondral lesion. Make sure that the cylinders are jam-packed and there is not too much of gap in between, and if there is a lot of gap, then you have to fill it up with fibrinogen gel or some kind of a matrix material that can fill up. The disadvantages is it is a technically demanding procedure. Some of the cylinders can break and fracture, and you can land up in a defect that can form cysts also. There are other disadvantages including anterior knee pain. Going on to Minsk cartilage procedure, it is a relatively new procedure and do not support any company, but I am showing these images because this is one of the most commonly used one. Arthrex has the autograft system, which the specific trick here is the graft net system, which which can be connected to the shaver system. You can go ahead with debriding a little bit of cartilage from the edges, from the relatively non-weight bearing areas, or from the loose body, that cartilage loose body that you have removed. It breaks the cartilage into small pieces, and that is mixed up with matrix material and can be added with ACP system in order to boost the regenerative potential of the cells over there. Then the recipient area is debrided as usual, and the minced cartilage along with the matrix and ACP is applied to the recipient area, and that solidifies over there and is expected to heal. What is the evidence? The evidence is limited because it's a relatively new procedure. It is being promoted as a single stage autologous procedure, autologous chondrocyte implantation. Basically, this also has chondrocytes. The studies have been very positive so far. In vitro and animal studies have shown the potential to produce extracellular matrix, chondrocyte growth, proliferation, differentiation, all of which are required for a good cartilage regeneration. Biological and histological and even immunohistological data have shown good results as comparable to autologous chondrocyte implantation. So that's a good thing. So maybe there is some hope for minced cartilage in future. Thank you.